Please watch all the way to the end. Don't forget to like and subscribe. Please leave a question or comment at the end. We'd love to respond. Don't forget, please check out our website at www.mypfi.org. So pelvic organ prolapse we talked about is a turning inside of the vagina. The vagina is falling out of the body. What used to be an innie pull up on the inside is now an outie. The vagina is bulging outward. The way to fix it is to get back inside the abdomen, find the back side of the vagina, pull it back up into place and hold it in place. The best way that we know how to do that, the most durable way, there used to be debate in the past, there's less debate of late, especially with the onset of robotic surgery and so forth. The best way we know how to do it is to find the back side of the vagina, attach a graft to the front wall of the vagina, attach a graft to the back wall of the vagina, and pull the whole thing up and tack it to the inside of a ligament high up on the tailbone. That's called a sacrocolpopexy. It's an abdominal sacrocolpopexy. It was pioneered, I believe, in the US. As most things go, we learned it from the Germans, but we won't go there. It was pioneered in the late 60s by a man named Dr. Alan Addison over at Duke University, who wrote an extensive paper on doing that procedure. It's called a sacrocolpopexy. Very risky procedure back in the day, required extensive surgical skill, high blood loss, high morbidity, etc. But it was shown to be very effective. He wrote a paper on it, and we've known that to be the gold standard for years. It was not used quite often as it should have been because of the complexity and the surgical skill required. With the onset of laparoscopy and robotic surgery, it became a more straightforward procedure. Blood loss dropped dramatically. The ability to do procedure got improved. And so we consider that to be the gold standard. Since that involves the use of mesh, synthetic mesh, some women don't want to have synthetic mesh. Some people have had complications previously from synthetic mesh that don't want any more mesh. They've had enough of mesh, thank you very much. Some people don't like the idea of polypropylene being inside their bodies. And so having said all of that, there's other techniques that people can go back to. One of the so-called native tissue repairs using your own tissue has been known for a long time. It's called an apical suspension. It was pioneered vaginally, but there's a way to do it abdominally, where the ligaments that stretched in the first place can be recreated and reattached to the top of the vagina. And that's called an apical suspension or a uterosacral suspension. The upside of that is that it uses no mesh, uses your own tissue. The downside of that is the same tissue that stretched the first time can stretch again. And we've also come to learn from some research that we've done with our own 3D MRI modeling with a technique called SV, levator ani subtended volume, which is a parameter that we developed in our laboratory years ago. We've shown that sagging of the pelvic floor muscles prevent the muscles from supporting the vagina. So if you do a native tissue apical suspension and you just pull up the top, there's nothing holding the vagina up, and that tissue, that procedure, apical suspension, is at risk for failure in the setting of sagging pelvic floor muscles. So the other alternative is to actually use sacrocolpopexy, but we've modified it so that at PFI, we've built upon that gold standard of the mesh-based sacrocolpopexy, using your own strong tissue, fascial tissue, to replace the graft and use that to support the vagina apically, pulling up at the top. That's turned out to be a really good procedure, and we've shown with LASV that it works better than the pure apical suspension in the setting where the muscles are sagging. So the best thing that we know of for fixing prolapse is the sacrocolpopexy. That's available to be done using synthetic mesh, or at PFI, we've elevated that game to the point where we can use your own fascial tissue. Much more complex surgery, much more involved, requires much more surgical skill to accomplish. That would be the gold standard. Other techniques involve going through the vagina and plicating or folding over, tightening the vaginal tissues to narrow the vagina down to make it look like the cystocele may be disappearing or the rectocele may be disappearing. The problem is still the vagina falling down, and unless you address that, you're gonna have a recurrence of the prolapse. It turns out there's a way to try and address that through the vagina by pulling up on the vagina and attaching it with a stitch to a ligament on the inside of the vagina called a sacrospinous ligament. And you tie a stitch around the ligament on the inside. It's different from the abdominal procedure. You tie a ligament, then you string the vagina back up, like pulling a flagpole and tying it down. That's one stitch. The front wall of the vagina, the back wall is still not addressed, so the recurrence rate can be pretty substantial. There's also a way to resuspend the vagina using the uterosacral ligaments, which can be accessed with some difficulty through the vagina as well, that has the same problem of not addressing the front and back wall and not being as durable. So those are the methods for solving prolapse. Back in the late 1800s, the only way we knew how to do it was to plicate or tighten up that front wall of the vagina. It was called a cystocele repair. Later in that century, and maybe even in the early 19th century, we developed methods, actually late 1800s, developed techniques for actually closing the vagina off, hemming the vagina back in, and there was a really brilliant way to close off the prolapse. The downside of that was pretty major for some women in that you couldn't use the vagina for sex anymore. And we've come to discover that many women ain't going for that no more. So we have other methods for addressing that problem. But the colpophyte is still an option. Surgical options for treating pelvic organ prolapse include ways to resuspend the vagina and pull it back into the pelvis. And these procedures can be performed either through the vagina or through the abdomen. Prolapse repair procedures include vaginal vault suspensions that can be performed via vaginal incisions, and they also include suspensions that can be performed via minimally invasive abdominal incisions, which involve resuspending the vagina to the tissues and ligaments on the inside of the body. Don't forget to like and subscribe. Please leave a comment or question. We'd love to respond. Don't forget, check out our website at www.mypfi.org. Thank you for listening.